There's actually a question that came in before we started that's sort of relevant to this. How common is it that the duroplasty would actually sag and extend down into the vertebrae from the prior decompression? Because that's kind of what you're talking about happening, some other blockage happening afterward. Why does that happen at all, and what's the significance? What happens from there?
I have occasionally seen that. It should not have clinical significance. So, the short answer, this is obviously a generous graft that was done. It's spacious, and that's what you want. You want a big graft that allows the brain to not be right up against the graft, but allows lots of fluid circulating around the brain between the brain and the graft so that it can't get stuck down. So you do want that. And this one was obviously pretty generous. That said, can you really have too much room? As far as the graft, no. People ask about bony decompressions. Can a decompression be too big? Well, of course. But typically, if it's like cutting a hole out of a shelf that a stack of books is sitting on. So if the hole is not as wide as the books, then the books are not going to fall down. And so we make a generous opening, but not, so generous that we end up having sagging of the brain. If you have sagging of the dura, it's not a pretty picture, but I don't think it has clinical significance. One thing I have seen more frequently is what was described as cerebellar slump, and that's been described in the literature with sagging of the brain. When I have explored those patients, I've actually found that the brain was stuck to the graft. So it's not that the brain had fallen down, it's that the brain was stuck to the graft and actually dragged down. And then when, we opened it and I was able to free the brain from the graft, then we got an MRI down the line and the brain has risen up. Mm-hmm. And I didn't, put more bone back or do a cranioplasty or anything like that. I just freed the brain from the graft and then, removed that graft so that it wouldn't just get stuck down again and replaced it with something else.
That's good. Also related to that, this came up in the chat. Does the dura scarring from that previous decompression, can that affect the surgical outcome, I guess, of the reoperation? So sure, you're going to go in and try and take that scarring out again and hope that it doesn't come back, but does that affect, I guess, the quality of life and symptomatology after the fact, or do you know?
Oh, I know.
Oh, okay.
that opens up a whole nother can of worms, but it's good, and I'll take you there. Okay, so when we go back in, we remove the scar. I've seen patients with terribly scarred brains. I mean, to the point that the brain and the graft had almost become one, and you had to really kind of carve it down, and then they do well. Another aspect of the study I was talking about from last year was looking at their outcomes, and their outcomes were all good or excellent. So their outcomes were mostly good or excellent, right, on the Chiari outcome scale. Nothing is 100%, but more than 90% of the patients had done very well. If they don't, there are comorbidities that go along with Chiari. There are cousins, and they are connective tissue disorder, Ehlers-Danlos being the most common in the Chiari patients. There's POTS, postural orthostatic tachycardia syndrome. There is hydrocephalus, communicating hydrocephalus. Those problems are more frequently found in patients who end up needing more surgeries. Mm-hmm. And they're also responsible for the symptoms going forward, more so than the fact that you had another Chiari operation. So if somebody comes back after a repeat Chiari surgery and I do an MRI and I can't find any fault with it, there's nothing tight, there's nothing that looks stuck down, the flow is good, everything looks good, then I look at whether there are comorbidities that account for the continued symptoms.